National Registry, and thank you for attending this webinar on the Paramedic Psychomotor Competency Portfolio Update. Just get my PowerPoint to run. I'm sorry here. There we go. So we are recording this webinar, and I ask that you hold all your questions till the end. Our administrative assistant, Suzanne Graham, will be gathering those questions, and I will answer as many as possible as time allows. So we're scheduled for 1 hour. So without further ado, now our objectives for today are to go over why are we changing the psychomotor exam, and how do we currently assess competency, what is a portfolio, and when will we be implementing this portfolio. So why did we look to change our current practice? Back in 2007, there was I like to call it a perfect storm. We knew that accreditation was coming. COA had been working with us, and we had known that 2013 was going to be our target date for coming out with requiring accreditation for all programs for paramedics. So initially we were looking to decrease the cost to programs, because accreditation does cost more money. So we were looking at different ways that the National Registry could defer some of those costs. And one of the things that we identified was the possibility of going to a scenario-based psychomotor exam with less skills to be evaluated instead of the traditional 12 skills. And now that we had all of our programs being compared to one standard and reporting to one organization with KHAP, we felt that we could move towards this way because we have some checks and some balances in place that we could move, look to a portfolio. We also had seen an increase in the use of simulations and high-fidelity mannequins and some scenario-based education. So we looked to shift some of the costs and resources by switching to the scenario-based exam, which wouldn't require, the thought was, as much manpower as an exam. So when we first started this out in 2007, we had a meeting in Ohio, and then we quickly, as we've gone over, we've involved hundreds of stakeholders from over 37 states, subject matter experts, pilot sites in the portfolio and scenario-based psychomotor exams. We've piloted this program with over 50 programs across the country since 2009, and we're currently piloting the program as we speak to make sure that people understand what's going on and working out some of the bugs in the program, so that when we roll it out after August 1st of 2016, everyone will have a good understanding of what the expectations are of the National Registry and how to implement it. So currently we have our 12 skills. They're assessed at one point in time, and that's how we assess psychomotor competency. We're looking to move towards a portfolio that assesses 33 skills over several months of the paramedic student's education. We're looking at them in the laboratory phase, in the clinical phase, and in the Capstone Field Internship. And they have this massive evidence, that we can show in a portfolio that the student has learned these skills, so that we do not need to actually evaluate just 12 distinct skills on one day, the day of the National Registry exam. We actually have this evidence so that we can make a judgment based off of that evidence, but we still need to put our hands on these people. We still need to give them a high-stakes environment and show that they can demonstrate their psychomotor competency. So we still do need to hold a psychomotor exam. And the end goal is they'll have 4 scenarios They'll come in and they'll demonstrate their competency in these 4 scenarios as a team leader, leading a team of 1 professional paramedic partner themselves, and then if it's more complex of a scenario, we might have some EMT, EMR assistants in there, but primarily it will be the student, or the candidate as we call them, and their professional paramedic partner that will run the call. Since this is such a big change, we're going to implement it in phases, and in the first phase, we are going to keep 5 of the current of the 12 skills. We're going to continue to evaluate them, and we're going to do that. That is the patient assessment trauma, the oral case A, oral case B, the dynamic cardiology and the static cardiology, and then that 1 out-of-hospital scenario. So it's some of the old, some of the new as we implement it, so it's not a big culture shock just going from one to the other. So we're going to take it in a phased implementation of this. Now, like I said earlier, this psychomotor competency, it's not just one individual performance. It's a massive evidence over time, and it's not only just how you perform individually doing the skill, but also the team dynamics we're looking at too. We're looking at the team member attributes early in their evaluation of the completion of the portfolio, and then at the end, we're looking at their team leadership. So not only do you need to be able to lead a team, but you need to know how to be a member of a team, which is really, when we're working out in the field as paramedics with one person, one other partner, or maybe several other people, you need to be able to work together. You're not out there just by yourself doing individual skills. You're working as a team, and either as a team member or a team leader, you need to know how to interact with others. So, and you'll also notice on this diagram here too that there's the 3 phases. There's the laboratory, the clinical, and the field phase. And there's overlap in this diagram where while people are demonstrating skills in the laboratory phase, they're doing this individual skills, they're then taking them and applying them in a scenario. And then there's overlap between the clinical. So if using IV as for instance, if I do my IV skills on the plastic can and I start documenting that and I start collecting skill sheets, whether electronic or paper, documenting my proficiency on that skill, and I get signed off and I move on to the next phase where I'm starting them on live person and partner in the class, then I start to apply them in scenarios. Well, after I've demonstrated in the scenario, the laboratory phase, I don't necessarily have to wait till I've done all of my skills in the laboratory phase before I move to the clinical phase. For those IV skills, I could move out, and now if I was going to do a rotation with the IV team, I'd be good to go with the IV team in the clinical phase. So there is overlap. But before you move to skill into the clinical phase, you need to have demonstrated that skill in the skills lab and the scenario lab, so that you have something to show that, hey, this person has an idea of what they're doing before we turn them loose on live patients in the hospital or emergency setting. Also, there's an overlap, can be an overlap between the clinical phase and the field phase. Some programs will send their students out and do ride-alongs on ambulances before they've finished off all their classroom, laboratory, and clinical education. And then in that sense, they're a team member. They may lead some calls, but for documentation for COA and for the National Registry, for their final Capstone Field Internship, those can't count as team leads. By all means, you want to track that information, but only after they've completed all of their classroom, their laboratory, their clinical education, do they move out into the true Capstone Field Internship on a 911 EMS unit where they're doing team leads. So with the portfolio, we're requiring that the student has documentation of the skills that they've performed in all their patient encounters. Now, one of the things that you want to make sure that you're doing with your students is documenting not only their successful skills, but also their unsuccessful. Most people coming into your program aren't coming in at the mastery level. They're not going to be, from day one, successful on all their skills. It takes them time. It takes them practice to build up to they get to the level where they can consistently start IVs, intubate patients, do a patient assessment. I mean, these are all things that we need to build upon. So you need to have, it's an expectation that, you know, you're going to start off and you're not going to be always getting things right while you're doing these evaluations, doing these skills. So we expect to see success and failure. So you need to document all that success, all that failure. Students that enroll in a paramedic program on or after August 1st of 2016, they are going to be taking a scenario-based examination, and they need to have this portfolio in place, or else they won't be eligible to take the psychomotor examination. So, and there's we have we've put together a manual on our PPC plan on how for a program to conduct this, and that's available on we've set up a Google Drive, and you can find that either from your program directors tab on the National Registry website, or you also can find that at the end of the presentation. I have a tiny URL link that I'll leave up on the screen. You can copy that down, and that'll take you right to it. After this is done, after your students have the portfolio and before they go to test, program directors are going to have to sign an attestation statement, and it's going to verify that the course was complete, there is a psychomotor portfolio, and that it validates the candidates has submitted all these documents and they've developed these psychomotor competencies before they're going to be able to test. Now, the National Registry will be verifying that this is done. It's possible that when COA comes out for their site visits, this might be one of the things that they look at also, because not only is this a requirement for us, but this requirement, we've worked in conjunction with COA when we developed this. And what we are requiring is very similar, if not the same, as what COA is requiring for documentation of the skills, scenarios, and patient encounters, and also for student evaluations, frequency, and documentation. So we've kind of meshed these two things together so that while you're doing it for the National Registry and this in one hand, you're also filling out a requirement of COA or vice versa. So we tried to work so that it's not two separate things that you have to develop. It's one thing that will fill two requirements. Now, the first phase of the student psychomotor education is the laboratory phase. This needs to be hands-on, frequently evaluated and documented. The forms that we designed with our subject matter experts for these skills are very detailed. They're not the typical ones that you see that most people are used to from the 12-step psychomotor exam for the National Registry. These are very detailed. They go into a lot of the skills and step by step by step. And they're designed not only to be used by a faculty evaluator, but they're also designed to be used by peer-to-peer evaluation. So it, again, when I said we were looking initially to defer some of the costs, instead of making all the evaluations driven by just faculty, we look to involve peer-to-peer evaluation with faculty oversight, or depending on the skills. But that would be something that your programs would need to look at individually to make sure that, you know, for whatever skill that you're doing. But again, so you have peer-to-peer, you have faculty, and you're recording all the attempts, especially the unsuccessful, to show that mass of evidence at the end of the student's education, that they were able to complete these things. And There are some, and it doesn't really show up well in the slide here, but there's some that need to have at least one instructor evaluation done on them. So that that's our subject matter experts. This is our best practice document that we came up with, and that was the recommendation of our committee of subject matter experts. If you look at these forms and these requirements and you determine that you want to make it more stringent for your program, that's perfectly acceptable. My suggestion is that you speak with your advisory board and your community of interest. You come up to a consensus of what you want to, what needs to be evaluated by an instructor, what can be peer-to-peer. And if you would like to make them more stringent than what we're using in our manual, by all means do that. Just like anything else, any other changes or any other things that you have in your documentation for your program, just document why you made the change, your justification. So when COA comes around and is looking at your documentation, or when National Registry comes to look, we have an understanding of why your community of interest and your advisory board thought that you needed to go above and beyond. Same thing if you looked at these and you decided that, hey, I don't think we need to have an evaluator sign off on this, it would be the same process. So in the skills lab, this is one of the evaluation forms. This is for the pediatric endotracheal, oral tracheal intubation. And it's there's the different categories, but it's they're step-by-step detailed forms. They're meant to be used in the formative phase. It can be either an instructor or peer-to-peer evaluation on these forms. We're looking at their management. We're also looking at their affect. We have critical criterion like we have on the current psychomotor evaluation forms that we use for the current forms that we use for the National Registry psychomotor exam. And some of the things we've added, we have a formal comment section for the evaluators to use. But one of the big things that we've added was the student self-evaluation. We want the student, every time they're evaluated, do you think you were successful or unsuccessful on this evaluation? And get them to reflect more on whether they thought they were successful or not, and then to stimulate a conversation and some thought as to what they can do to improve their performance. So with the skills phase, we learned a couple lessons with piloting this and sending it out to for the past few years. And number one, it takes time. Number two, do they have to memorize all these steps of this skill? And the other thing is that there's different learning styles. So let me back up one slide here too. I hit double tapped here. This is what might be the traditional way of running a skills lab. You've got an evaluator who's talking to the students, and the students are standing around and soaking up all the knowledge. What might be missing here, though, is no one's touching the patient. The scenario-based, we need to hands-on, doing the skill, applying the skill, and less of the war stories. With talking to the people that have implemented and helped us in the pilot programs for this, the students don't really have a problem with this new way of the scenario-based education. They're on board with it, and they get it. The problems the program directors tell me that they have are the instructors. I mean, we're all human. We fall into our own habits. We like to teach the way we were taught, and the sage on high disseminating wisdom to the students. Well, we need to kind of break ourselves of that model, and more of students interacting with the patient and applying that knowledge versus standing back and listening to someone talk about it. Another thing we learned too was the paperwork. It does take a lot of paperwork if you're going to do this all on paper. It takes a lot of space. For our purposes, we don't care whether if it's done on paper, electronically, a combination of both. At the end of the day, we just need to have that mass of knowledge. Whether you have a big binder that's 6 inches thick, 8 inches thick, and has all this paper in it, or if you have an electronic file that either you have created or a commercial product that you have gone with that provides that information. You know, we've worked early on with FISDAP. I know Platinum has a product, and there's a couple others out there that have products that electronically capture this, which is fine. And just at the end of the day, you're able to get that information to us and to use it for yourself to evaluate what's working in your program, what's not working in your program. You know, look at the data and where is that aha moment where, you know, my students, you know, after so many IVs, my students seem to get it. And after that point, they keep getting it. And, you know, they've started to internalize this skill and really be able to practice this skill with regularity and show competency in that skill. Sorry here, we'll quick on the tab here. The second component then is the scenario lab. And as soon as the students have demonstrated those individual skills in the skills lab, you need to take them and put them into scenario lab. And at the beginning, these could be very simplistic scenarios. It might just be a patient assessment scenario where they're going in and they're assessing a patient. And then as they add IV, they go in and they assess a patient that needs an IV, and they establish the IV. And you just keep adding complexity to these cases as they gain more skills and knowledge. But it needs to be hands-on, needs to be frequently evaluated, and needs to be documented. And we need to record all attempts, especially the unsuccessful, to show this massive knowledge that and this massive evidence we need for our portfolio. Now, this is Appendix A of the PPCP manual. It outlines the different scenarios that need to be evaluated in the scenario component of the laboratory phase. Now here, let me blow it up a little bit. These are the different topic areas, and they're similar to the NEMSIS dispatch information. This is a summative phase now where we're looking, at the end of the day, we're looking that students have been successful on 4 adult patient leads, 3 successful pediatric leads, and 3 geriatric leads, and 10 successful team member evaluations. Now, that doesn't have to be done in each one of these topic areas. It's an overall in the topic areas, but you want to cover all these topic areas because these are types of patients that we commonly see in the emergency setting, and we want to make sure that they've been exposed to these types of patients. Now, in order to help facilitate the creation of scenarios are new to a lot of people, but there are also a lot of people that have been out there using scenarios for years and having great success with them. We did create a scenario template. Initially, we were looking back in 2012, 2013. We were going to try to make the scenario scored on an electronic format. So we were going to, when you came to the exam, we'd have evaluators there with templates, with tablets, I'm sorry. And with that tablet device, they would score the candidate's attempt. And so we developed this template to put into the computer system to develop these the scenarios. Well, unfortunately, we ran into some logistical problems. Not all programs had access to tablets or computers where they could put them in the rooms to be used for evaluation. Not all these tablets could be linked electronically, which was one of the requirements for the scoring. So we had to back away from doing the electronic scoring for now. We have it on the shelf, and as time and technology catches up, we'll look at it again and evaluate if we could possibly go to an electronic scoring. But from it, though, came this template that we've used. Also came all of the forms that we used. Those were all Plan B in case on exam day that everything didn't work. We always had a paper backup that we could go to. You could go to a computer, print them off. Well, Plan B has become Plan A now, and we're reusing that as our method for scoring this. So it's a 4-page document, this template. The first page is the equipment, setup, background, and moulage that you need to have for the scenario. This is the prep stuff you want to do ahead of time. You want to make sure that you have ready to go when you're setting up this scenario. The next thing is next page would be the dispatch and scene survey. So you're going to read to the candidate where they can't see you what they've been dispatched to. And then they, along with their professional partner, will come into the testing area to treat this patient. Scene survey is things they're going to see as they're coming into the room. Very well may be a hazard that they need to address. In this case, we've got a throw rug that's balled up inside the testing area, so it's an obvious trip hazard. If they, either they need to walk around it and make sure their partner walks around it, or just as easy, reach down, pick it up, move it to the side so it's out of the way, so they can have access to the patient. We looked to get away from set weights on a lot of patients where the weight doesn't make a difference. This way we can move it towards what's believable for this simulated patient they're seeing, but this way that they're also held accountable to if there's going to be a weight-based dosage or a calculation that needs to be made based on weight, we'll have those ranges. And then the mechanism of injury or the nature of illness. In this case, it's an abdominal pain patient. The third page contains the primary assessment, the history, the past medical history, and examination findings. So this is the meat and the potatoes of when the student is in doing their evaluation of what is wrong and their examination of the patient, what's wrong. This is meant to be upfront so the evaluator can look at this and provide any information or ensure that the simulated patient is providing the correct information to the candidate as they are testing. You'll notice that there's some that have just 3 dashes going across. When there's 3 dashes across, that's just a normal finding. There's nothing of any significance in that category. So instead of listing a whole litany of things that aren't wrong with the patient, we just list the things that are pertinent and are wrong with the patient. So it cuts down on the time it takes the evaluator to locate information for the candidate. And then the final page is the expected patient management that needs to be done for the patient, for the candidate to be successful. Any additional resources that they need to request on the scene, an event. So at some point during the scenario, we'd like to put in something that happens that would happen in real life that the team leader needs to address. In this situation, you have there's evidence of dogs in the home as they approach the scene, and then 5 minutes into the scenario, you start playing a tape of a barking dog. So all for this, we just need to make sure that the team leader ensures that the dog has been secured or the dog's in another room and not going to come scurrying into the room and start fighting providers. So we have that little event, and it varies. It could be a change in patient condition. It can be an outside thing like this with a dog. It'll just be so it's not that static. Scene safety, BSI, hokey pokey, we shake our hands, we do the jazz hands as we're entering the scenario, and then we completely forget about scene safety throughout the remainder of the scenario. This is meant to be more like real life, where you constantly need to reevaluate what is going on in your environment to make sure that you, your partner, and your patient and any other person on the scene stay safe. So this is just looking to test that also. And we look for transport decisions. Where does this patient need to be taken based on their condition, and any mandatory actions or potentially harmful or dangerous actions that the candidate could perform that would be detrimental to the patient. This is a sample of the team leader evaluation form for the scenario lab. It is similar to what we will use when we're evaluating them during the exam, but this is what we put out there for programs to use. Gives you places at the top to document the student's information, who the evaluator is, whether it's an instructor or a peer, the age group of the patient, and then the topic area that's being evaluated. It's important that you track this information. This way you know what you've evaluated the students over, the different topic areas that you've evaluated the students over. We also have a 3-point Likert scale that we are to score the patients on. And this way it's not so much cut and dried, successful, unsuccessful. They're students, we give them that little gray area. For any of you who have looked at the previous documents that we had out on our website for the PPCP, this is something that's new to this document. Talking with the subject matter experts, we felt that it was important that we give a little bit of flexibility while they're still in the student phase. Also, the topic areas is something new that we added, and that's based on input that we received from our subject matter experts who've been working with us to develop this instrument. Also, if you look at what we're evaluating, all along we've said, even with the old evaluation forms that we used on our current psychomotor exam, we stressed that this is not a linear document. You don't have to follow things from the top to the bottom in order to be successful, but in a lot of cases, that's what's been taught, and that's what the students try to replicate, that top to bottom. The critical criterion is really meant to catch things that should be done in a certain order or a certain time frame. So on this form, we kind of flipped it a little bit. We took scene safety and we moved it further down. You'll see that when you get to the next page. And we put leadership as the first category. Again, it's not a linear document. This is just a placeholder for where to document this. And it's going to be interesting to see how people go along with this. And these are the different topic areas from before. Just blew them up a little bit in the Likert scale, so it's a little easier to see. And this is the second page, and the top of the second page is your scene size up, making sure that you're taking charge, making sure everything's safe. Then your assessment and management and your field impression. Again, it is more detailed than the current forms that we use, but again, this is meant to be used peer-to-peer and evaluator, so it does have that extra areas for them to document in. And then again, we do have critical criterion, a comment section, and whether this, again, with this, just like the skills lab, does a student think that they were successful or were they unsuccessful? And it helps them to start to internalize their performance and evaluate their performance so that they learn from what they've done. So that is a 3-page document. It is a little longer than our current forms, but again, we want to make this so that not only can an instructor use it, but peer-to-peer use it and get value out of it. And then the team members evaluation. So not only are we evaluating team leadership, but we also want to make sure that during education and the development of the portfolio, we want to evaluate team membership and document all the students' team membership abilities. So we do have a team membership evaluation form that is done while the students are working in the scenario. It is not as detailed. This is only a 2-page, but again, we're looking at their fellowship and we're looking at their scene safety and their management. Again, they have critical criteria, comments, and that student self-evaluation. were you successful today in this skill, in this scenario? So as we've been piloting this, we've been looking for lessons that we have learned, and one of the things is we've learned that if it's not documented, remember, if it's not documented, it didn't happen. And talking to a lot of the site visitors from COA, not often, but sometimes they'll find only one evaluation sheet documenting successful completion of a skill or scenario in a student's current documentation of when they look at their records. And with this portfolio, though, we require that all attempts need to be documented to show that progression from successful to from unsuccessful to successful as the students grow and learn more about these skills and start to internalize them more and develop that massive evidence that demonstrates their competency in these skills and scenarios. And we want to build on our scenarios as our courses progress. You can't just start off with the final scenario. You have to start out simple and then add complexity as they learn additional skills. And you need to train like you're going to fight. This is a big thing. The way you learn, the way you reinforce your learning is the way you're going to practice it when you get out into the field. Anecdotally speaking to a lot of, as people have gone through this portfolio, the feedback they've received from the preceptors, from the in the field, in the clinical setting, and employers was, what are you doing different with these people? They're coming out and they're actually able to, after they've been successful, either when they're going out to the field or going to the clinical site, they're better prepared. And then when they're getting hired at the end of the day, after they become certified and then licensed by the state, they're better prepared to function as a paramedic. And their question was, what did you do to these people to make them better prepared? And a lot of it goes back to this portfolio, because we're practicing treating patients, not practicing and reinforcing 12 discrete skills. We're learning how to treat a patient. Also, there's been some anecdotal evidence that it's elevated critical thinking. When we initially piloted this back in 2009, we looked at the cohort who were involved in the initial PPC pilot and looked at their cognitive scores on the National Registry Cognitive Exam, and we compared it to the cohort that had went through the previous class, and we found that not only were their psychomotor skills better, but also that their scores on the National Registry Cognitive Exam had gone up, and we attribute that to the elevated critical thinking skills that they learned by managing a patient and not just learning and reinforcing 12 discrete skills. So the clinical phase, like I said earlier, can overlap the other phases. Some programs may choose to keep it completely separate, but again, that's a programmatic decision. But before you move into the clinical phase, you need to have shown competency in whatever skill you're going to be practicing in a clinical setting. You need to show competency in the skills and scenario lab before you move into the clinical phase. In the clinical phase, it needs to be hands-on. It needs to be frequently evaluated and documented. You need to record all attempts, especially unsuccessful. Again, it's showing a massive knowledge for this portfolio. It's repetitive, but that's what we're doing. We're developing this massive knowledge. Now, this is the current form that we're using for the evaluation, and it provides areas for the students and the preceptors to document all patient encounters in the clinical setting. And the student goes first. They do their evaluation. Preceptor comes by afterwards. They discuss anything, disparate ratings. Why did the student think they were successful? The differences between what the student and the preceptor feel the students had in the skills. And it helps the student to learn what they need to change in order to be more successful. You have a student that beats up on themselves and thinks they're not successful when the preceptor says, yeah, you're doing an okay job. It helps to both ways, not for students to learn how to become better and the students that already have it to gain more confidence. We have an area here for comments. If there's an action plan needs to be done for future shifts, we have an area for that. We have an area for the evaluator to request follow-up from the program, place for everyone to sign, and also some brief instructions to help the preceptor in completing the evaluation in a standardized format, so that, you know, I know all programs have provided education to the preceptors, but we want to make sure that this reinforces what they need to do for their evaluations. So the lessons that we've learned. So these are the clinical areas that we're going over: the airway, the trauma, medical, cardiac, OB, and behavioral. And if you're doing something different, again, discuss it with your advisory board and document it like you would for COA. And some of the lessons that we learned, though, emergency departments are busy. Imagine that. And it's a lot more paperwork, and it was difficulty with clinical buy-in. So what happened, initially we had abbreviated evaluation forms that we're using in the clinical setting. And speaking with our the people that we involved, subject matter experts that we involved, they weren't getting these forms done. It was too burdensome for the clinical setting. So we've actually gone and we've removed them, and we're just using the form that I just showed you. If your program is able to do this and the preceptors are able to do it, by all means keep it. Just again, document it, discuss it with your community of interest, and provide the documentation through your advisory board minutes of why you're doing that. And then the final phase is the field phase, the Capstone Field Internship. And this is performed when they completed all of their classroom, laboratory, and clinical education. It's when they are on the ALS ambulance responding to emergency calls, and they are the team leader. They might not be performing all the skills, but they are the ones leading the call and running the call. For this, we have a form that's very similar to the form that we used in the clinical phase. One of the things with this, though, is we do have a minimum number of team leads. In order to be successful, you have to have demonstrated that in 18 of your last 20 patient contacts, you were successful as a team leader. That's one of our requirements. This form is completed by the field preceptor after each rotation. Again, we have provided area for the instructions, areas for comments like we did on the clinical form. Again, we want to make sure that the documentation is done in a standardized format. So lessons we learned from this, not much has changed with this from the previous way, the current way that we're doing things. Again, the students do feel that the preceptors feel the students are better prepared, and because they're practicing they're practicing treating patients, not just skills. And things that we saw in the scenario lab and the skills lab with the students repeated themselves out into the field. So it's important to make sure we get things right in the classroom, in the lab, before we move these people out into the field to practice on patients. So what does this portfolio look like? It can be an electronic format, which is on the left of the screen, or it can be a paper format, which is on the right of the screen, or a combination of both. It doesn't matter to us, just as long as you have that record of what they are doing. So our implementation. After August 1st of 2016, any student that's enrolled on or after, any student that's enrolled in your program need to have a portfolio, and so that they can test for NREMT psychomotor examination. And again, we will be doing, these are the different skills that are going to be done in the first phase. It's going to be the patient assessment trauma, the 2 orals, the 2 cardiologies, and then an out-of-hospital scenario. There'll be the student as the candidate, and then they will have 1 professional paramedic partner provided on all cases, and then possibly, based on the complexity of the call, they might have an EMR, EMT, or several in the case of a cardiac arrest, where you're going to have people there to do the compression, so the student and the professional partner don't need to be doing that. When we do it, this is the proposed template. After we go to full implementation, there'll be 1 pediatric scenario, 2 adult scenarios, 1 geriatric will be your different patient types, and then they'll have all these different, for those 4 different patients, this will be your different types of complaints that they may see. And so it'll be randomized by the National Registry. No one will know what it is until the rep shows up to administer it, and this way the candidates need to prepare to treat patients with all of these conditions and not just focus on one specific conditions. There's some next steps that we're taking. We're working on the logistics of candidate flow, the team membership, how many examiners we need, additional staff we need, equipment, facilities, technical requirements, costs. We're evaluating all these things as we go along with our test sites now to try to have all these questions answered as we implement. We are continuing to pilot this format to make sure that it works. We are working with our Standards and Exam Committee from our Board of Directors. We actually meet with them next week to discuss this process to make sure we're meeting the expectations of them and our community of interest. They represent our community of interest very well, so we look at them for guidance. We are piloting in additional states throughout the country, again, to make sure that we've taken the manual that we published at the beginning of this year, we put it out there, we've taken programs that have not been involved with this process in the past, and here's the manual. Set up your program, make sure it works. And of course, we're not just turning them loose on their own. Call us if you have any questions. And we've also found them mentors from previous programs to work with them to answer any questions that they have as things go along. We continue to promote the PPC through webinars like this, through national and state EMS conferences, through our quarterly newsletter. We've been promoting this, which many of you have, was how you guys became involved in and found out about this webinar, and other forums where we can meet to go over anywhere we can go through this. Now, everyone in their, we're doing updates. If you go to the Program Directors tab, this PPC process has been available since 2013 on the Program Directors tab. We're trying to, get this out. We're just, trying to re-emphasize this, and that's why we've made, at the end, you'll see the link where anyone can go to it. We're not just defining it to program directors. We're trying to work on refining and tuning up the process. Phase 1 again launches and will be effective after August 1st of 16. Is when we will, they're going to need to work on their portfolios. We're still we'll be discussing with our Standards Exam Committee when we'll start testing with this, but programs are going to need to start compiling a portfolio after August 1st of 16. And this is the link to the portfolio on our Google Drive. And I'm going to look at Suzanne has given me a couple of questions we have. We do have a few minutes here left. We've got about 10 minutes left before the end of the conference call here. So the first question is, will it be available at a later date? Yes, I have recorded this. I will be putting it on our website. I will, if you go to the Google Drive, I've created a folder there where I have a document that'll have the link on it. I couldn't figure out how to put the link on the Google Drive, so you just go to the Google Drive and the link will be there. Also, if you go to our website and you type in webinars into the search engine, it'll take you to the webinars and it will be there. So, second question, if doing evals on all participants, how many instructors are you anticipating having to be present to evaluate the team leader and to evaluate the assists? So, two different ways. When you are doing it in the scenario lab, while they're in their education. A lot of the programs, what they've done is you can use the students to evaluate, to be your evaluators of the team members. So you can have one student, break your students into teams, and one team will be tested and the other team will be helping with the evaluation. So out of that team that's helping with the evaluations, you'll have your simulated patient. You'll have any additional providers if you need. You'll have evaluators. So they can sit there and they can evaluate the students while they're being done in the scenario lab. So you're kind of using your students as resources to do these evaluations, and then either having the peer-to-peer for the team leader or having the instructor doing the evaluation of the team leader. As when we do it in the, we implement it into the scenario-based psychomotor examination, we will have one evaluator that will be there evaluating the team leader, the simulated patient, and the professional partner can also help to evaluate the student afterwards. So just like our current scenarios where you're doing hands-on things, you can use your simulated patient and your professional partner to provide feedback to the evaluator. But there will be just one lead evaluator who's responsible for documenting everything and signing off on it. We would have liked to evaluate the team member. That was our initial goal too, was to put two students in an evaluate, have a, one's a team member, the other's a team leader, and evaluate both of them. But the logistics of that and the fact that you could fail as a team leader because of a team member's actions, a lot of our stakeholders had problems with that, so we felt that we needed to keep it just cut and dry. On that day, you're being evaluated as the team leader, and that's it for our scenario for when we're judging your psychomotor competency that leads to certification. The traditional spinal immobilization is changing. How best to incorporate the changes? Yes, they are changing. We have not. We still need to speak with our standards and exam committee and come up with a position paper on that, which we will be putting out before we make any changes. So currently, we try to make the patients that need to be on a backboard meet most of the criteria, and they're unresponsive, they have significant injuries. But that will be something that we'll be looking at as time goes on. Next question was changes that will be made to the AMT level psychomotor exam. There aren't any changes currently that will be made to the AMT. The AMT will remain as it is. There has been talk about using scenarios for AEMTs, but we'll have to make sure that we've developed all the background before we're able to do that. We're going to need to have a way to verify that they have this portfolio and it's done in a consistent manner. So that'll be something, it's a discussion for down the road, but it also, I think, would be interesting if we could do that for the AEMTs also. Okay, the test starts August 1st, so students starting in January but not finishing until December will take the new test. So if you start before August 1st, you are not required to have a portfolio, no matter when you finish. We don't know when we're going to switch this over to go live. We still need to have that discussion with our standards and exam committee, and once we come up with a decision on that, we will get that out, an implementation date out, when that will be. But at this time, we're not sure when that will be. And as far as I-99 and AMT final testing, they will continue to be tested the way they currently are. Another question, if you want to become part of the pilot, who do you contact? That would be me. Send me send me an email. One thing that I do need to make sure, though, is when your students start their skills and when they will be finishing their program. They're doing their final portion of their program. So we need to have them finishing early in 16 in order to be able to gather data on them and to utilize it. We will, as far as who will be training specific proctors at the test sites, that will be up to the programs to train the evaluators. The National Registry representatives that administer the exam, they will be trained by us. Training programs provided, not that I'm aware of at this time. If they're, in the past, we have done webinars on psychomotor evaluation for the current form, so that might be a possibility. If enough of members of our of the public request that, we could move towards that. That's a good question. Question about the templates for the scenario lab and the scenarios that we're developing. Are they concrete at this time, or are we still working on them? We are still working on them, but are these templates, and except for the few you shalls, you shall have 18 of the last 20. Those you have to have team leads in your Capstone Field Internship, but. So those are absolutes. The rest of this document is a best practice. If you have something that works better for your program that you would like to use going forward, again, document why you're not using our best practice, why your current practice works. And if you have a scenario format that you use that works for you now, and you'd like to continue to use that for your students, you just need to document why, your rationale behind with your community of interest and your advisory board, and that should be fine. A timeline for how long phase 1 will be used. We don't have that yet. We have some tentative dates, but again, we need to discuss that with our standards and exam committee, and once we have discussed that with them, we will move forward with that. If I have a class that starts January of 2016, will those students be required to have a PPC because they will test their practical after August 16th? No, they will not. If they start before August 1st of 2016, students will not be required to have a portfolio. Although, I would suggest that you might want to have a portfolio just to meet the requirements of COA. The portfolio meets the documentation requirements and a bunch of the different requirements that COA has. So it might be a good time for people to look at it, start practicing to get that together. And for my final question here, and this is a good one that I should have covered earlier, time frame for the scenarios. When we are testing the candidates, they will have 20 minutes for their scenario. So depending on the complexity of the scenarios that you run with your students, you might want to look at that time frame just to get them familiar with working in that time frame with patient contacts. So I thank all of you that have taken the time out of your day to listen. If you have any further questions, go ahead and continue to forward them. Suzanne has been collecting them and forwarding them to me, and we will try to get back to you on them. And if you have any questions, you can give me you can contact me at the National Registry. And I should have added that slide. I'm sorry. My email address is tvreeland@nremt.org. And I'll try to answer all your questions as quickly as possible. And again, thank you, and have a great day.